goals of these videos are to understand the normal anatomy and the appearance of normal anatomy on radiographs. We will discuss how to identify ligamentous and osseous injuries on x-rays and how the injury pattern affects stability and choice of treatment. So the ankle joint, or also known as the talocrural joint, is made up of three bones: the tibia, the fibula, and the talus. More specifically, the distal tibia is known as the plafond, the distal projection of the fibula is known as the lateral malleolus, the medial projection of the tibia is the medial malleolus, and the posterior malleolus is the posterior aspect of the tibial plafond. The ankle ligament complex is made up of three groups: the lateral ligament complex, the medial ligament complex, which is predominantly the deltoid ligament, and the syndesmotic ligaments. The lateral ligaments are the main stabilizers to inversion of the ankle and are made up of the anterior talofibular ligament, the calcaneofibular ligament, and the posterior talofibular ligament. The syndesmosis is made up of a osseous articulation between the distal fibula and the distal tibia at the incisura fibularis and is made up of anterior and posterior ligaments. Predominantly anteriorly, the anterior inferior tibiofibular ligament is the main component. Posteriorly, there's a complex of ligaments made up of the posterior inferior tibiofibular ligament, the inferior transverse ligament, and then the interosseous ligament, which continues as interosseous membrane as you move more proximally. Medially, the deltoid ligament is made up of two main components: the superficial layer as well as the deep layer. The deep component is made up of the anterior and the posterior tibiotalar ligaments. While both the superficial and the deep components can be injured, it is thought that with rotational ankle fractures, that injury to the deep component of the deltoid ligament leads to lateral talar shift and malalignment of the mortise. Typically, for the evaluation of ankle fractures, three views of the ankle are obtained with the patient non-weight bearing, and these include the AP, the mortise, and the lateral x-ray. The AP view is taken with the x-ray beam centered on the anterior aspect of the ankle. The lateral radiograph of the ankle is obtained by centering the x-ray beam on the medial malleolus. A perfect lateral x-ray demonstrates one line representing the talar dome. With malrotation, oftentimes two lines are seen. Furthermore, on a perfect lateral x-ray, the posterior border of the fibula lies slightly anterior to the posterior border of the tibia. This is important because syndesmotic malalignment can oftentimes be detected on a lateral radiograph, but only if it is a perfect lateral radiograph. The mortise view is obtained by internally rotating the ankle approximately 10 to 15 degrees. This view allows us to assess the symmetry of the medial clear space in relation to the superior and lateral clear spaces, and is very important in determining lateral translation of the talus. Additionally, the mortise view is helpful for assessing syndesmotic alignment and for assessing ligamentous injury by evaluating the medial clear space, tibiofibular overlap, and the tibiofibular clear space. Three important radiographic parameters that we will discuss later in this video. Over-rotation or insufficient rotation in obtaining the mortise X-ray can make comparison of the clear spaces difficult. The medial clear space is the radiographic clear space between the medial border of the talar body and the lateral edge of the medial malleolus. Medial clear space is a proxy for the integrity of the deep deltoid ligament. If the deep deltoid ligament is injured, the medial clear space becomes wide under stress. In general, while there are different ways to measure the medial clear space, a widening of 4 to 5 millimeters or a medial clear space greater than the superior clear space is typically thought to represent a deep deltoid ligament injury and an unstable mortise. The tibiofibular overlap is the radiographic overlap between the medial border of the fibula and the lateral border of the tibia. The tibiofibular overlap gives an understanding of whether the syndesmosis may be malaligned. The tibiofibular clear space is the radiolucent area between the medial border of the fibula and incisura tibularis and is demonstrated here. While the medial clear space, tibiofibular overlap, and tibiofibular clear space may appear normal with very subtle malalignment, overall these radiographic parameters are excellent measures for determining alignment of the mortise. This image demonstrates the tibiofibular overlap and clear space on a mortise X-ray as it's correlated with an axial CAT scan reformat. See you in the next video. Thanks for watching.